I'm thrilled to be interviewing Professor Jeffrey Donnan from Melbourne. He's been involved in many of the groundbreaking trials that we use to treat our patients today. ECAS, Hermes, Extend IA, many other ones. And one of my favorite papers as well, 1026 experimental treatments in stroke. He is an officer of the Order of Australia. I believe only 3,000 people have that, right? And
That's about it, yes.
yeah, and a past president of the World Stroke Organization, and was also a chair of the World Congress of Neurology, and received many awards for his contributions to the field. So my first question would be: we've come a long way from hemodilution back in the 70s and aspirin, just aspirin. And now we're perfecting the art of thrombectomy and playing around with antiplatelets and anticoagulants, trying to decrease the times from onset to reperfusion. What do you think is the next hurdle in improving our outcomes?
That's a very good question. I've just had time to reflect on this with an article I've written with my friend and colleague of 30 or 40 years standing, Stephen Davis, for cerebrovascular disease about the basically the history of the ischemic penumbra, and more or less the history of intervention in ischemic stroke. Acute ischemic stroke is the history of the ischemic penumbra, because if we hadn't understood about the ischemic penumbra pioneered by Lindsay Simon, we wouldn't be where we are today. So if I just took ischemic stroke to start with, I think the next big steps are to firstly refine how we do thrombectomy, because you know that in the human time, these devices we use are still fairly primitive, and it may be that we're able in the not too distant future perhaps even not have groin puncture, but have better ways to undertake thrombectomy, perhaps by distant movement of magnets, etc., etc. I think that's a strong possibility, and before that to just refine the mechanical thrombectomy devices we've got, because of course the quicker we reperfuse, the better the outcome. And secondly, the means of reperfusing with the thrombolytic agents, I think, is going to improve even further, because even though we now have more or less tenecteplase, which is not inferior and probably superior in a lot of ways to TPA, I think there are going to be further developments, not only to be able to remove the clot, but also to reduce the bleeding risk, which is not good. And the final thing, or perhaps final quick two things, the issue of intracerebral hemorrhage. I think this is the bridesmaid of acute stroke, and I think we're going to make huge advances over the next few years. I think of the hemostatic agents. I think at least one of those is going to be proven to be effective in the not too distant future, and also cleverer ways of doing interventional surgery, because the ways we've got at the moment are far too blunt and probably far too late. And then there's very finally is the whole pre-hospital stroke area, which I'm also heavily involved in as mobile stroke ambulances. And here in Australia, we're planning to put lightweight imaging in aircraft, which is, to me, incredibly exciting.
Wow. So many questions about everything you've said. I I don't know where to start, but I think I'm gonna go down the line from why do you think that tenecteplase is so slow to adapt around the world, considering it has been shown to be quite effective, simpler to use, definitely in a pre-hospital setting where you don't need to drip anything, you just give it. Are people just scared, you think, or is it regulations and so on?
I think it's the matter of just accumulating evidence, Ivo. I think it takes time to do this. Remember that the first paper by Mark Parsons, which I was involved in, published in the New England Journal, was only a small phase 2 study. And then we published Extend IA with tenecteplase, which does seem to reperfuse better than with TPA. But again, the numbers weren't great. And then there's the TASTE trial, which is still going, which is a very large trial, over 300 patients. I think that's going to be completed, and I think provide that additional evidence. And remember, then there was the rather confusing NORTEST trial, which showed with a higher dose, the hemorrhage rate was highish,
Yeah,
and the benefit wasn't huge. So that slowed things down a bit. But the problem with NORTEST was that the strokes were so mild. I think there was a very, very strong ceiling effect. I think the mean NIHSS, if I recall, was only about 4, and that, in anyone's language, is pretty mild stroke. So
yeah,
I think it's time. But I agree with you. It's I work on the stroke ambulance, and our stroke ambulance has been going for about 3.5 years, nearly 4 years, and I very quickly switched over to tenecteplase because it was so easy to give. And
yeah,
rather than having an intravenous line trailing you into the hospital, it was done and dusted within a few seconds.
yeah, yeah. Excellent, excellent. So, keeping on topic with the MSU, I know that you have an MSU and you've written papers that it's not only effective in terms of treatment, but effective even financially, which is, not that many of us, even, best MSU, we're still working on it here in Houston to get that paper out. But now you are working on a helicopter, as you said, and you want to get some imaging in there, whether it's a CT, like I think the Scandinavians are trying as well. Um, so considering all the obstacles that I'm sure you've had with your mobiles, how do you think, how is it going to be to implement a helicopter? And do you think that that's going to be effective, cost effective, and so on?
No, that's a very, very good question. And I first must congratulate you guys in Houston too, for and also the Berlin guys with Enric out about, and of course with you guys, with our great friend Jim Grotter, to have 2 trials positive to provide level 1 evidence that this is the way to go is an incredibly powerful message to governments around the world, and it's certainly helping us here in Australia to spread mobile stroke units all over the country. So we're in the process of getting a second one in Melbourne. There'll be a third one in Sydney soon, and other major cities will follow suit, and largely because of what you guys have done. So the helicopter and fixed wing, we're working on fixed wing aircraft with the Royal Flying Doctor Service as well. I think will be almost a no-brainer for cost effectiveness, because the distances we have here and you do there to retrieve people are so great. To be able to triage them on the spot would be, I think, unbelievable. And just to mention that we've just been funded with a $40 million grant.
Wow, congratulations.
To move this forward. And we've got 3 companies we're working with basically to to develop these lightweight imaging devices, and one of them's two of them are small startup companies. One using electromagnetic or microwave technology, which is pretty exciting. But the barrier there is to get the sensitivity and specificity to exclude blood. And we hope they make it, but we'll certainly help them get there. But that's a bridge to cross. The second is another small startup with cold ray technology for standard CT. So there are no moving parts, and that enables them to get the weight down from what's half a tonne serotom to probably under 100 kilograms. And the third is to take a standard, working with one of the larger companies to just change the materials within the existing type of half-tonne serotom type scanner. So we have one or more of those will come through, and then we'll start to do the clinical trials to prove effectiveness, and embedded in that will be the health economic analysis, which you must always do.
Oh, that's very, very exciting. Do you think that considering these new technologies with low field MRIs that like hyperfine and these that are coming out, do you think you'll ever get an MRI in there?
That's a really good question, and we met with Hyperfine. I was very excited about their development. I think their development is fantastic, and as we all know, it's being rolled out on the ground rather than on mobile platforms. What we've found in discussion with them is there's a long way to go getting an MRI on a mobile platform, either on the ground or in the air, because of the difficulties with field strength, and also with MRI, just the fact that there are the number of people you can actually scan is a little bit lower than with a CT scan. But it may be in the more distant future we get an MRI on moving platforms as well. I hope so.
Yeah, that would be amazing. Amazing. Maybe also in the future, there might be some biomarkers that might be interesting to use as well. I know that they're coming out, and I think that you were on a paper that talked about biomarkers predicting hemorrhage with thrombolysis in S100B and SE and so on. Do you think that biomarkers will come into our daily practice in mobile situations, but also in our ED?
They may, although they've been around for so long now, haven't they? And GFAP is the other one. It's it's a tough one, isn't it? I suspect that they might make it as an augmentary tool, but I suspect we're going to always have to have an image of some sort. They might become useful more in a global sense when we think of almost 2/3 of the world's population hasn't got access to imaging the way we're fortunate enough to have access to imaging. And it may be, if we can get the sensitivity and specificity up a bit higher, it may be a way of triaging people a lot better. But I suspect in more sophisticated settings that we're fortunate enough to be living within, it'd be very much an add-on rather than a primary measure of making the diagnosis. But I do find it exciting and interesting, but I think imaging for us is the number one priority.
Yeah. So do you have any do you feel that any particular, I know that you're also besides the diagnosis of acute stroke and the treatment of acute stroke, you're also interested in rehabilitation of stroke. I see you've been involved in some, rehabilitation trials. Do you think there's anything on the horizon which shows promise currently that we should be paying attention to?
I'm glad you drew attention to that, because when when we're discussing, the next big steps, I think that is another. It's such a yawning gap, isn't it? That here
Yeah.
we have about a third of the cost that we undertake in stroke. Once we've passed the front end that a lot of us are tied up in, the rehabilitation side is much more evidence-free in terms of how we go about it. And we, with Julie Bernhardt, a very close colleague here in Melbourne, ran the AVERT trial. She was the leader, and for the first time took rehabilitation to a new level, with, instead of what they tended to do with very, very small trials with, say, 50 to 100 patients, she took it to over 2,000 patients, and showed that early rehabilitation within 24 hours really didn't work, or early mobilisation, at least the way it was designed. So I think the big move forward in rehabilitation is all in trial design, and superimposed upon that are different interventions that we might think of. So, for example, with another trial that's being undertaken is with Kate Hayward, who's working on the upper limb, which is a template for rehabilitation generally, but it's a very nice template to use, and using innovative trial design with dose response, because dose is a huge issue in rehabilitation. How much to give, how often, and when. No one really knows the answer to that. And I think it's back to the drawing board with innovative dose response studies to get the dose, the timing right, and then expand it into a bigger trial. And we work with a brilliant trial designer and statistician, Leonard Cherloff, who's got these umbrella designs, these platform designs, these, you name it, ways of cleverly, seamlessly moving from phase 2B to 3 trials without losing patients. That is very, very clever. And I think that's the way things are going to go with rehabilitation.
Well, excellent. Yeah. Looking forward to the development of that field. Another field that I think is exciting, but we haven't really done much with yet that I know of, is neuroprotectants, right? There are so many agents that we have looked into. Most have not shown any, probably all have not shown anything very promising, despite clever trial designs like FastMag and so on. And we're still looking for that agent. How do you feel about that?
Well, one of the most frustrating areas of research, which we invested very heavily in, as a lot of people did, Pat Lydon and others who are really great leaders in this area, Englo and others, Mark Fisher, of course. It has been a very, very frustrating area. And you alluded to that paper we published years ago now, with David Howells and others, showing that the number of, with over 1,000 different publications with no result, etc., etc. And it's still unclear as to why it's untranslatable into humans. But at least I think, and many labs around the world closed because you just couldn't get neuroprotective research funded. In fact, if you put the word neuroprotection in your grant, it barely got past the door. But I think there's an element of hope now with the NA1 compound, as you know, that Michael Hill is dealing with. I think that's quite promising, and their next trial is still running with that very interesting sub-analysis with reference to the impeding effect of TPA. And there are others coming through. And I think it's on the back of reperfusion therapies and post-reperfusion injury that we might be able to ameliorate. That is the next possible step forward. I can't see any other way forward for neuroprotection than that one, and I really hope that we're going to get somewhere with this latest avenue.
Yeah, me too. Do you think that maybe we'll be good enough in selecting people who are at high risk for strokes and giving them secondary prevention, perhaps? Because at the time they have a stroke, it's probably way more difficult to make their brain cells and neurons more resilient to injury than maybe preemptively protecting them.
Yes, that's very true, Ivo. And you would know in the animal models you can get a much even more profound effect if you preload them
Yeah,
and then create the injury. And the very nice example was the way Michael Hill did it initially with his NA1 compound was to use as a phase 2 model delayed ischemia and subarachnoid hemorrhage. That's a very, very neat way to go about it because it's effectively preloading, as you're saying,
yeah,
having the whole not only neurons but astroglia, etc., oligodendrocytes awash in neuroprotectant, ready to be then assaulted. I think that's a very, very good way to do it. And if the other example is around surgical procedures, cardiac, carotid endarterectomy, angioplasty, all of these mechanical interventions, I think, are ripe for trial with NA1 type compounds to see if it's going to be more effective as you say, a very early secondary prevention rather than late.
yeah. It makes a lot of sense, especially as you say around those high risk procedures. We get
Exactly,
consulted
exactly.
daily, almost daily. Yeah,
Yes, yes, they're very commonly performed all around the world. So the potential usage of them is massive.
yeah, yeah. Right. So couple of general questions. We did go into several areas of stroke so far. Um, so if you were just finishing your stroke education and you had to do it all again starting today, um, it's hard to focus your attention on everything, even though it's all exciting. What would you recommend to a young, fellow or somebody starting their career? Which direction do you think it's worth pushing in at this moment?
Well, firstly, I would say I wish I was at that stage now because it is so exciting. There is so much going on.
Yeah,
Remember when I started training in neurology in 1976, 77, it was even before uh, aspirin, which was 1978. So when I started, there was zero, and CT was just coming in when I was a younger resident because we didn't start our training until we'd graduated for about 4 years. But there was no imaging as well. So what a change there's been. So if I would love to be starting my career right now, I would be so excited. To be frank, I think all the things you and I have chatted about, each of them is so interesting and each with so many possibilities. I would follow my heart and opportunity uh, to to move into an area that I thought you were going to be able to make a difference. And as we know, that's not only uh, individually what tends to interest an individual, but also what opportunities come your way to work with someone or a group that is absolutely first class. And I think that's a very important principle, is to work with first class people so that when you start out on your training, you understand how to perform first-class research. And I was very fortunate during my training to work with outstanding individuals who really, really did undertake research at the highest level, so that we're able to carry that through. So I wouldn't dare to suggest to an individual go into thrombolysis or thrombectomy, or although I must put a personal bias here. I must say, if I were young, I would love to be an interventional neurologist. I think it's so exciting, but that's a very personal thing.
Yeah, yeah. Well, despite the fact that you started in the 70s, you've had a very long and influential career, and I'm sure that you have many interests in life. You were actually extremely active even in your young years. In even high school, I read you were on debating, football, athletics, cricket, swimming, tennis. So how do you balance all of your interests and an influential career with your life?
Well, I think that's the other advice to young people, is to have as balanced a life as possible. And I've been very fortunate throughout my career to have a wonderful wife and partner, and two wonderful daughters, and that certainly brings you back down to earth, particularly your daughters, who think you're fairly hopeless. So I think having that life balance is very important, and I think to don't burn out, pace yourself. And everyone approaches this differently, but the way I did was I didn't ever work at night, which seems strange, but I always wanted that time with my family. So the additional work I did very early in the morning. And that was just a personal thing. Other people do it the other way around and spend time with their family and then work very late at night. But you need to have a rhythm where you don't burn out and overdo it, and make sure that you have that right balance with either family, colleagues, or other activities. You mentioned sport, etc. I've always had an interest in as much exercise as possible, jogging particularly, a bit of golf. So you need to make sure that you're not obsessed with your work. Otherwise, I think you become a bit unbalanced.
Yeah, good advice. One last question is, what do you think is the best field in medicine to be in now, and why is it stroke?
Well, I think stroke is one of the best, and the reason I say that is, especially as I mentioned very early on, having just reviewed the history of the journey we've had with the ischemic penumbra over 40 years or so, from zero interventions of any sort being of proven value when I started, to now a myriad of primary, secondary, acute, and even some rehabilitation interventions that are proven to be beneficial. I can't think of an area of medicine where there have been so many advances from nothing through to so much in such a short time, and that's why I think stroke is so exciting. Recognising, of course, there are other areas of medicine that have almost been as exciting, virology and vaccines, etc., which of course are very current and top of mind at the moment, are pretty hard to compete with, and it's another very, very exciting area of medicine. But stroke is pretty hard to pass.
Agreed. All right. Well, thank you very much for your time today. Um, and for your very insightful answers into our field. I really enjoyed our talk.
Ivo, enjoyed it enormously, and thank you very much for taking an interest. And I hope your listeners will find it and watchers will find it of at least some interest.
Definitely.